So, we know the Reproduction procedures were able to bring down the last 4 decades, the mortality but not the morbidity, which almost remained the same. So, that means what actually we achieved is the efficient management of the complications and decreasing the mortality but unable to lower the complications. The Achilles heel obviously is the pancreatic fistula, which leads to all the 3 other complications, and the sepsis, like where the sepsis can drive again the development of the hemorrhage and the gastric emptying. So till the ISGPS defined the criteria were not uniformly in the grading of this pancreatic fistula, and which they modified again in 2016, which they classified the clinically relevant pancreatic fistula. Using this, our present fistula rate is between 11 to 33%, and this actually is a retrospective. So you can't use this for mitigating any of the development of pancreatic fistula individual patient to patient. It only helps us to compare between the different institutes of the grade of the fistula. So all of us, so many prospective, retrospective data has identified the risk factors to develop pancreatic fistula, the patient factors, the anatomical, pathological factors, and the surgical factors. What we can actually mitigate or decrease by addressing the surgical factors in this group, and very limited control of the patient, where you can modify these factors by intraoperatively adjusting it. So these are all the modifiable risk factors which is in our control, but obviously we know that nutrition is one of the important factors, and what we can do preoperatively is that. Apart from that, the surgical factors. The most tested initially was octreotide, which was actually found not much of use. Then NEJM articles found that the pesirotide is useful, but subsequent meta-analysis no benefit. Recent article has shown a single-arm trial, lanreotide, a long-acting drug is supposed to be beneficial. We are waiting for the SWOG phase 3 trial, which is in progress, which should address this. But only problem with this is very expensive. So as of today, there is no strong evidence of this pharmacotherapy in reducing the pancreatic fistula. Then the issue of the ischemia, the watershed area at the neck, as the previous speaker has already highlighted. Strasberg addressed this issue long time back. There was debated by many other surgeons. But we know that there is a watershed area, so one should transect probably to the 5 to 10 millimeters to the left of the portal vein, so that you are away from the watershed area, so that the stump is less ischemic. And how you transect also has been addressed by many of the pancreatic surgeons. Scalpel, you will not have a collateral damage, but it produces a lot of bleed. So the energy devices, the bleeding will be less, but it produces more of collateral damage to the pancreas. So probably via media, particularly with the advent of minimally invasive, we are using these energy devices. You settle lower energy so that you have a lesser collateral damage, and the surface hemostasis by fine sutures is important in securing a hemostasis. So some of surgeons have said that don't mobilize too much of the pancreas, but many of the surgeons and even we don't agree for this, because you have to mobilize technically for some anastomosis like pancreatic or gastrostomy, etc. So I think that might not be the factor, but ischemia of the cuthead is definitely an important factor which probably predisposes to the development of the pancreatic fistula, particularly the Blumgard procedure, which has been used most of the minimally invasive surgery where they put a U-stitch, and one study has found that they have used ICG guided before tightening the U-stitch, and they found that using this criteria they were able to bring down the fistula rate to a certain extent, but it has to be validated by other studies as well. So most of the studies on how anastomosis is done, most of the studies have revolved around these. Like whether you do a pancreatic or jejunal anastomosis, the type of anastomosis, or mucosa to mucosa, or invagination, or a pancreatic or gastrostomy. Though there is a conflicting evidence for all this, no procedure has proved superior to another. But one thing is the anastomotic principles have been highlighted in all this. One should maintain a good vascularity. You have to avoid bowel edema, so that the fluid administration by your anesthetist should not produce too much of edema, or it should not be, you should not use indiscriminate use of vasopressor agents in this, so producing ischemia. See that there is no tension. Sutures like PDS should be used, and usage of magnification also is very important if you want to make your soothing perfect. So these are the various techniques of invagination this is what we usually do, the Heidelberg modification is what we use, invagination, and cattle valve duct to mucosa. This is a technique where you only anastomose the pancreatic duct to the mucosa of the jejunum. And the lumbar technique is performed mainly by the minimally invasive surgeons. It's much more easier to do this procedure than invagination of mucosa. And Peng is the first person who has produced his paper 0% what we discussed in the morning, but it is he claimed 0% degrade, and this is pancreatic gastrostomy, which is popularized from the Armenian Institute paper, and subsequently a lot of papers are come out on this. So, so many procedures are there, what actually the literature suggests of these different. So, invagination versus duct to mucosa. The initial RCT meta-analysis did not show any benefit, but subsequent meta-analysis showed that invagination is slightly superior in that to only in high-risk gland. And pancreatic jejunostomy versus pancreatic gastrostomy conflicting results, and meta-analysis showed that the recent meta-analysis has showed that pancreatic gastrostomy has a slight advantage of reducing the pancreatic fistula, but at the cost of bleed from the stomach. So lumbar is technically much more easier, so and the results of this lumbar procedure is comparable to that of pancreatic jejunostomy. Binding, as I said, his original article claimed that none of the patients are pancreatically. We did a small RCT and we found that there is no difference in the pancreatic fistula rate between binding and invagination. And similarly, the meta-analysis afterwards came also showed that the leak rate was similar to that of binding versus invagination. Another major controversy is the blood loss. So a lot of studies have shown that patients who have blood loss of more than 700 have high incidence of leak rate. So that has been addressed consistently in many of these trials, and then so based on this, I think it is recommended that these high-risk procedures, high-risk pancreatic procedures should be done by high-volume centers. The patient has good experience, a meticulous dissection, and a hemostasis. Just to minimize the blood loss, probably addresses this issue of blood loss. Then came the stent. So the stent, compare external stent versus internal stent. So the external stent is more beneficial than the internal stent. So, but it is not again consistent in different trials. And another, these two trials have shown that the external stent is only beneficial in small duct rather than the big ducts. So if the high-risk pancreas has duct size less than 3 millimeters, only the external stent is useful. But only problem with external stent, most of all the surgeons use the infant tube. Actually, doesn't have much of a side hole, it might block it. So if you are using, one should use a smaller diameter, or you can use the special pancreatic stents available where it can drain more effectively. Probably they might be useful in using a stent with small ducts. Next issue was the role of drains. There was some debate whether routine drainage doesn't lower the morbidity and mortality. Following this paper, an RCT was conducted, which was published in Annals, and they tried to control by elimination of drain completely versus drain. And they found that there is high morbidity and mortality in the drainless patients, and in fact they have to stop the study. And now the Claudia Bassi after that advised that early removal of the drain in low risk. What it means low risk is if you find less than 5,000 units of drain you develop on day 3, it should be removed by day 3. And we have already discussed post-pancreatectomy, pancreatitis. I think I skipped this. So the other procedures which probably one can address is fluid overload. This is very important. These patients should have they should not be on either hyperperfusion or hypoperfusion. Both are dangerous. Hypoperfusion produces pancreatitis and hypoperfusion produces edema and fluid overload. So the patient should have adequate fluid overload is what should be addressed both intraoperatively and postoperatively. And a lot of techniques, modified techniques, though it's been not validated in a randomized control trial, one can use a momentum, falciform and other tissue sealants or anastomosis. Then High-risk patients, some surgeons prefer doing a prophylactic total pancreatectomy, though many of the surgeons do not agree. We also don't agree in doing total pancreatectomy. In Indian scenario, I think handling a total pancreatectomy patient, the brittle divert is very difficult. Probably, I think Ramesh was telling that we do pancreatostomy. Probably, I don't have any experience on that, so I discussed that issue anyway. The future direction should be, one should be able to critically identify the groups based on the fistula score. ICG-based subvascularity should be assessed before anastomosis, and probably we should look for more effective pharmacotherapeutic agents in the future. And inducing fibrotic agents probably in the future, based on the observation, we found that patients who had a neoadjuvant therapy, post-neoadjuvant therapy, pancreatectomy has got a low fistula rate, probably because of the increased fibrosis. To conclude, one should assess the high-risk patient by using the proper fistula score, should follow ERAS protocols, and pharmacotherapy is doubtful. Fluid management should be well balanced to have a good perfusion, at the same time do not produce any edema, minimize the blood loss, and the transection of the neck prefer to be on to the left of the portal vein. And anastomotic technique, I think surgeons should master one technique, use magnifying lenses. And high-risk pancreas, probably one should resort to either invagination or a pancreatic or gastrotomy. Stent should only be reserved in high-risk patients, that is soft gland with less than 3 millimeters, probably one might use, and early removal of the external drain if it is appropriate. That means if the drain fluid amylase is less than 5,000, you should remove it by T3. And of course, the post-pancreatectomy, acute pancreatitis role should be critically looked at now with new data coming in. Thank you.
Anybody has any experience with ICG evaluation system for pancreatic disease?
I think Rajesh, if I don't have any thing.
We did evaluate ICG in pancreas after the close but not for pancreatic stump. We did it to assess the vascularity of the pyloric stump and its effect on the biliary gastric empty. This is the 2 years of our organisers thesis on this. We could not find any statistical correlation. The biggest reservation, another fellow has done ICG in his implication, trying to see if it makes difference to the gangrenous bowel, whether you can save more bowel or to resect more bowel based on the ICG. We could not find any statistical significance even there. We use ICG from Vascular, the ICG system, which is supposed to be the best. We also use the 1788 Striker. We have tried to use both the systems at this point of time with the available technology. I personally feel that it does not help in assessing vascularity. It is very good for the oncological aspects, speaking of liver tumors, thoracic ducts, stomachs, and neurons. But unless we have the quantification in that system, it may not be clinically all that good. I'm sure it does help us, but with the naked eye, and I'm talking about the immunofluorescence that we tend to pick up, we can only find out whether it's bright or less bright. And there's a lot of bias in assessing that effect of ICG on vascularity at this point of time. But all of them say that they are going to bring in now quantification. So you will get a scoring system when you try to focus it on some viscous, and probably that might help us in deciding whether